Thanks very much for having me today. And I apologize I'm not able to be there in person. I was there last year with the Northern California chapter and had a great time and great experience in Sacramento and hope to be able to come in future years. We wanted to provide a brief update on what's happening with the Medicare Access and CHIP Reauthorization Act of 2015 and the implementation of that. This was a law that was actually passed in 2015. And right now we are in the proposed rule stage. We just got the proposed rule about 3 weeks ago. We are still trying to dig into the over 900-page regulation and try to determine what the impact is going to be on the health IT community, but also on the broader healthcare community. So I'm going to take the next few minutes and just run through what's included in the rules. I have a number of slides here, but I think in the interest of keeping to your agenda, I'm just going to kind of run through them pretty quickly, and then happy to answer any questions and follow up in due time with folks as questions arise. So as I mentioned, MACRA, affectionately known as MACRA, was passed into law in April 2015. Repeals the sustainable growth rate formula. And what it really tries to do is decrease the clinician burden on reporting by streamlining multiple quality reporting programs, really trying to provide incentive payments for participating in alternative payment models and what's referred to in the proposal as advanced alternative payment models, and then sustaining Medicare by paying for what works. So as Ian talked about, this is really part and parcel of the entire shift from volume to value. This is a real critical piece of that entire move. So the law offers multiple pathways for offering varying levels of provider risk and reward, again, to ensure that more payments are tied to value, and expanding the opportunities for a broad range of providers to participate in the APMs over time. So I think it's important to recognize the underlying theme of this entire program, of this entire piece, is health IT is really critical to quality reporting and to provider payments moving forward. So it's a real critical and I guess some would say significant piece moving forward. So what MACRA does is creates two different tracks for providers. Providers can choose either the MIPS track, which is the merit-based incentive payment system, or they can choose the APM track. There's significant differences between the two different tracks. Under MIPS, there is both a positive or a negative adjustment that comes into play. Under the advanced alternative payment model track, there really is only upside for participation in that track. So there is a bonus that's associated with the alternative payment track, but then there's also the chance for a positive or a negative payment adjustment under the MIPS track. So just keep that in mind as we move forward. MIPS is made up of 4 different pieces, 4 different performance categories: quality, resource use, clinical practice improvement activities, and advancing care information. For us in the health IT world, advancing care information for the Medicare Clinician or Medicare physician community, advancing care information is the new meaningful use category. So we're going to talk a little bit more about that as moving forward. But these are the four different categories under MIPS. Again, with ACI being the new meaningful use piece of MIPS. So who's really covered under MIPS? Defining the MIPS eligible clinicians. What we're talking about is clinicians who bill Medicare for Part B services. These include right now physicians, physician's assistants, nurse practitioners, clinical nurse specialists, certified registered nurse anesthetists. So this is for all Medicare Part B clinicians are going to report through MIPS. Their proposal right now includes the performance year beginning in January 2017 for a 2019 payment year. So again, January 1st, 2017 is slated to be the start of this program, with a full year reporting period in 2017, and then for which would reconcile with a 2019 payment year for any sort of positive, negative, or neutral adjustment for their Part B payments. So the Secretary of HHS actually has the opportunity, the option to expand MIPS participation to other types of clinicians in year 3 of the program. And some examples of some other types of clinicians that the Secretary could choose to expand the MIPS or eligible clinician designation to include the following: physical or occupational therapists, audiologists, and clinical psychologists, and so on. So, and clinicians can choose to participate individually or as a group. They would be assessed across all the 4 different MIPS categories. There are some clinicians who are going to be exempted from any sort of payment adjustments, both positive and negative, under MIPS. If they're newly enrolled in Medicare, if they have $10,000 or less in Medicare charges, or 100 or fewer Medicare patients, or they are participating in advanced APM, which we'll talk about in a minute, they do not have to participate in MIPS. So the weighting of the different categories under the MIPS program is as follows. Quality is going to make up for the first year of the program, 2017 performance year. Quality is going to make up 50% of the MIPS program. Advancing care information, again, the new quote-unquote meaningful use is going to consist of 25%. Resource use or cost is going to be 10%. And clinical practice improvement activities are going to be 15%. So these weights are proposed to change by year. Right now, you can see with the purple bar kind of in the middle of the screen under quality, the real shift is going to occur between the emphasis on quality right now to a greater emphasis on cost down the road in 2021 and beyond. So it's really the 2017-2019 part. Quality makes up 50%, cost only makes up 10%. That's going to shift to a 30-30 breakdown, which I think has, with the idea being as clinicians come more on board with the program and understand that they're going to be held more accountable for the cost of the care that they're delivering to their patients, in addition to ensuring that they maintain high quality. So quality is made up of 6 different measures that clinicians have to report on. They have to be outcome measures, high priority measures, cross-cutting measures. We have definitions for all of these in more detail in different briefs that we have. In the interest of time, I'm just going to skip ahead to what's included under clinical practice improvement. There's actually 90 activities which are slated for inclusion under clinical practice improvement. It can be something as simple as extended office hours for a practice to ensure that they are accommodating more patients in their care. But clinicians really have the choice to choose the activities that are best suited for their practice. There's also partial credit for participation in advanced APMs. There's also full credit for those practices that are medical homes as well. So under resource use, there's actually no reporting that's going to be required under resource use. These are all going to be claims-based measures that CMS is going to take care of the reporting for the physician. Again, going back to the theme of trying to reduce the burden placed on physicians to report a number of these different objectives and measures. So under advancing care information, again, the idea is that this is going to supplant the meaningful use program for clinicians, for these Part B clinicians. So there's going to be certain requirements, but the idea is also that these measures are going to focus on ensuring interoperability and information exchange, and but clinicians are going to really be rewarded for their performance on the measures that matter the most. So some of the key differences, I think, between meaningful use and advancing care information. Meaningful use, as probably most of you know, there was a requirement that all objectives and measures had to be reported on. advancing care information and this new paradigm, what we're talking about is a real streamlined measure set that emphasizes slightly different things. One important point to emphasize is that clinical decision support and CPOE are no longer going to be required for these clinicians to report under advancing care information. One size fits all was also a real onerous part of the meaningful use program. Under advancing care information, clinicians are really going to have the opportunity to customize which measures they want to report on. All or nothing under meaningful use has really been eliminated for a lot more flexibility, multiple paths to success for clinicians under advancing care information, and a real strong alignment under advancing care information for clinical quality reporting. That was maybe not in complete alignment under meaningful use. So one other thing that I want to point out to folks, just in terms of what's required for all meaningful use providers. So they go back to acute care hospitals and critical access hospitals, as well as reporting under the ACI provisions here, is that there are two other attestations that clinicians and, again, more broadly, meaningful use providers have to abide by. And these attestations have to do with cooperation in terms of surveillance of certified EHR technology, and then also providers are going to have to attest to not blocking health information exchange are going to have to attest to facilitating health information exchange and not blocking any sort of information exchange. This is something that we can go into more detail on, but again, it's important to note that these are provisions that are covered under the ACI portion of MIPS, but are also broader and are going to be new provisions attached to all meaningful use providers. So what's really going to stack up in terms of the MIPS calculation? Again, as I mentioned, there's going to be the opportunity for negative or positive adjustments. The idea is that folks, clinicians are going to be fall either in the negative side of our composite score and the threshold established by CMS, and they will have a negative adjustment in 2019. But there's also going to be clinicians who have a neutral adjustment, do not receive a positive or negative adjustment, but fall into the neutral category. But then there's also going to be a lot of physicians that are going to fall into the positive side of things. This is a zero-sum game, budget neutral program, especially on the MIPS side. Anything that comes out of MIPS and payment adjustments on one side have to be paid out into positive payment adjustments for clinicians on the other side. So there's also this provision about $500 million in additional performance bonuses for exceptional performance. These are the really high achievers that we're talking about. CMS wants to ensure that they are not going to lose any sort of incentives because they already have reached a lot of the thresholds, or doing a lot of these already performing at a high level. So they don't really need to. They need these extra incentives in order to continue to try to improve the care that they're delivering. So. Real quick, I'm just going to run through what's required under the APM track. I know you have a full agenda today, so I want to try to just press on really quickly what's included here. Again, for the APM track, what we're talking about is a January 1st, 2017 start with a 2019 performance year. So again, clinicians have to choose to either participate on the MIPS side or participate on the APM side. So if folks choose and are eligible and meet all the requirements to participate on the APM side, they would become what's called a qualifying APM participant. That's a QP as noted on here. So those folks that are participating as a QP, a qualifying APM participant, are not required to report under the MIPS program. So there's, as I said, that there's a bonus for participating in the APM track, and that's going to be a lump sum payment in 2019 for clinicians who a 5% lump sum payment for clinicians for their prior year Part B billings and for their covered professional services. So that 5% incentive lump sum payment is going to last from 2019 through 2025. So these are the requirements. Suffice it to say, there's some complexity around who actually is eligible to participate in the APM track. There is a threshold that clinicians have to meet in terms of the amount of their Medicare billings that are in the APM track, and also their Medicare patients that are participating in the APM track. So the real three requirements for participating in advanced APMs is participants. These qualifying participants have to use certified EHR technology. There has to be the provision of payments for covered professional services based on a lot of the quality measures and that are included under MIPS. And also the real key provision here is about the idea about bearing more than the nominal amount of risk. So there has to be some sort of an advanced payment model that is bearing risk in terms of incentivizing positive adjustments, but also the possibility of, if they don't meet the thresholds that they have to meet in terms of the savings and the quality care that they're delivering, that there is a downside, a negative payment adjustment possible as part of this plan. So I'm just going to skip ahead to what we're talking about and what's in the proposal for the advanced APMs for the 2017-2019 payment year. So Track 2 of the Medicare Shared Savings Program, ACO program, Track 3 of the Medicare Shared Savings Program, and the Next Generation ACO model are three of the advanced APMs that CMS has designated in the proposed rule as meeting the qualifications to participate in the APM track. So clinicians who participate in one of these models outlined here are eligible to participate in the APM track, and eligible, if they meet those other requirements, to receive that 5% lump sum payment. What's not included is the Medicare Shared Savings Program Track 1. That track does not meet this nominal financial risk component that we discussed previously, because under Track 1 of the Medicare Shared Savings Program, there's only upside to that program, and there's no potential for downside, no potential for any sort of negative payment adjustment that goes along with that. And also, the bundled payment for care improvement, the BPCI program, is not included as one of the advanced APMs. The other advanced APMs is the Comprehensive Care Plus, the so-called CPC Plus program, ESRD, end-stage renal disease large dialysis organization program participants are also eligible for participation in an advanced APM. And then in 2018, the oncology care model, two-side risk arrangement, is going to come on board as an advanced APM. So I'll just stop my presentation right here. I hope you can see just in even this brief presentation how complex this is, all the different choices that clinicians have to make, the different burdens that are going to be placed on them for decisions, and also for quality reporting side of things. So this just speaks to some of the decisions that they have to make, whether they are in an alternative payment model. If that alternative payment model is an advanced alternative payment model, they can follow this particular path forward. If they're an alternative payment model, but that's not an advanced alternative payment model, they have to follow a different track into the MIPS side. And then even under MIPS, they have to determine if they meet the thresholds required for MIPS participation. If they don't, then they're not subject to MIPS. If they do, they are subject to MIPS. So again, a lot of decisions, a lot of complexity that has pretty tight timelines to implement.